Welcome to Oncology Morning Commute, managing adverse events that occur with PARP inhibition therapies, what your patients need to know. Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from GlaxoSmithKline and Merck Sharp and Dohme Corporation. In this podcast, Dr. Robert Coleman and Dr. Kathleen Moore continue their discussion about PARP inhibitors and take it down to the clinical level. Who are the best candidates for these therapies, and how are adverse events managed for the best outcomes? Information about the faculty and disclosures can be found at morningcommutepodcast.com/ovarian cancer 2. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Coleman is the Chief Scientific Officer at U.S. Oncology Research at Texas Oncology, Shenandoah, Texas. Dr. Moore is the Associate Director of Clinical Research in the Department of Gynecologic Oncology at the Stevenson Cancer Center in Oklahoma City, Oklahoma. I am your host, Candace Hoffman. Dr. Coleman will begin our discussion.
Welcome back, everyone. We're here for the second of 3 podcasts talking about PARP inhibitors and ovarian cancer. This has been, as I mentioned in the last podcast, a very exciting time for us. This is obviously one of our most important drug assets that we use in our patients with both frontline and, in some cases, recurrent ovarian cancer. And we've talked a lot about the efficacy and the story of how these drugs became available to us in management. And to slightly recap that, we talked about the preclinical work. We talked about how it got into the clinic, showed how it could shrink tumors in molecularly annotated populations. And then we showed that it was expanded into broader use as a switch maintenance in platinum-sensitive recurrent ovarian cancer, and then ultimately into the frontline setting. So fortunately, we've had about a decade worth of experience with PARP inhibitors. They've come to us most in a couple different formulations. Kind of midstream, we changed from the capsule formulation of olaparib to the tablet formulation. But with this, we've seen kind of a consistency, not only in efficacy, but also in the effects on our patients. So the side effects, toxicities, et cetera. And so we thought we'd dedicate this podcast to talking about the adverse events that we see with PARP inhibitors, especially in patients that could be anticipated to be on a PARP inhibitor for a long time. You may remember in the first podcast that we talked about some of these patients being, many of them being on treatment through the anticipated duration of exposure that was predefined by the study in the frontline setting, which could be as many as 2 to 3 years, depending on the drug. But in the recurrent setting, we've seen these given to the time of progression, and many people have been on these drugs for a long period of time. So we want to talk a little bit about what the impact this can cause to patients, their toxicities that we see as kind of immediate ones and those that are more long-term. And ultimately, I want to close with a discussion on one of the concerns that has been raised even before we got started with PARP inhibitors in the clinic, and that's the risk for MDS and AML, secondary malignancies. So again, joining me today, Dr. Kathleen Moore from the Stevenson Cancer Center at Oklahoma University. As many of you know, Dr. Moore has been instrumental in this development story of PARP inhibitors and has led several trials, including the SOLO-1 trial, which really provided the first major hit in the frontline setting, demonstrating what we think will be now cures for patients at a higher rate than we anticipated without using these drugs. So it's been quite a journey for us. So we're so pleased to be able to have Dr. Moore with us today. Katie, welcome, and thanks for joining us for podcast number 2.
Absolutely, happy to be here.
So why don't we start off with just kind of like the general tolerance or tolerability of PARP inhibitors in your experience. You've obviously treated a lot of patients in kind of all the disease settings that we've mentioned. What's your kind of general impression as to the tolerance or tolerability of these drugs?
That's a great question. And honestly, the best people to answer that question are our patients who we subject to all of these therapies. because I have sort of clinical trial data that I can comment on and then just direct patient experience. The clinical trial data would suggest, and I think accurately so, that PARP inhibitors are well tolerated by our patients, but not without some toxicity. And so, what we how we counsel our patients is very consistent with what the clinical trial data suggests, that there's very frequent but low severity fatigue and nausea. Those are the main things that are kind of almost ubiquitous, like over 60 to 70% of recipients of a PARP inhibitor will have those symptoms, but usually just grade 1 or 2 when you're using CTCAE 5.0 grading. You can see anemia in about a quarter of patients that's severe enough to consider a transfusion. So that would be grade 3, less than 8. And then you can have about 20 to 25% of our patients complaining of sort of other GI toxicities like diarrhea or constipation or dysgeusia, which can be bothersome. All of these are low grade with the exception of the anemia, but being low grade doesn't mean they're not bothersome. So, it's a very different experience for our patients. And I think this really goes into the appropriate pretreatment counseling. Patients have just finished 6 or 8 or however many cycles of chemotherapy, usually given on a 21-day cycle, where they get an infusion with steroids, and the next day they usually feel pretty good. And then they have like 3 days of feeling pretty crummy, and then they start to feel better and better, and then we treat them again. So there's these peaks and troughs of toxicity. Now with any oral medication, but we're talking about PARP inhibitors, the peaks and troughs are gone. And it's just this sort of constant low grade kind of a nuisance background that for some patients can be very bothersome, and other patients just sort of breeze through it. And so there's a lot of individualization in terms of how patients experience these toxicities and kind of the adjustments we need to make for each individual patient based on her perception of distress related to those side effects.
Great. Yeah, thank you so much for that. So you mentioned some, kind of classify these into hematologic and non-hematologic. And as you mentioned, the hematologic toxicities we run into, I guess they're more problematic, or anemia. But we do see other hematologic toxicities, such as neutropenia and thrombocytopenia. And I wonder, we've had a lot of experience with these adverse events in the recurrent setting. And now more so now, so much in the frontline setting. But are all of these PARP inhibitors, rucaparib, veliparib, niraparib, olaparib, do they all have the same potential for these adverse events? Maybe just break it down into hematologic and non-hematologic. So with respect to hematologic toxicity, are they all the same, or do we look at these patients potentially differently based on the drug we choose?
So they do have, so there's a lot of what we call class effects of the PARP inhibitors. And we talked about those main ones with the GI toxicities and fatigue. And then you have the class effects that are hematologic, but those are the side effects where you do see some variation between the PARP inhibitors. Veliparib, we kind of fairly or unfairly refer to it as the least potent PARP inhibitor, although it's quite a good PARP inhibitor, probably has the lowest amount of hematologic toxicity from anemia, thrombocytopenia, or neutropenia. And then we have olaparib, rucaparib, and niraparib, which on the surface are similar in terms of how potent they are. I think the next escalation up is talazoparib, which unfortunately is not a drug that is available to us for use in ovarian cancer. But olaparib, niraparib, and rucaparib are similar, but they do have differences. So you'll see across all 3 of them, it's about 25-ish% of patients will have grade 3 or higher anemia. With a little bit of wiggle room, but the confidence intervals overlap. So I think that anemia is relatively similar. Thrombocytopenia does vary though. So for olaparib and rucaparib, the incidence of grade 3 or higher thrombocytopenia is really negligible. It's only about 6%. And for niraparib, with individualized starting dose, so based on baseline weight and baseline platelet count, if you use that to individualize your starting dose, you get about a 13% risk of grade 3 and up thrombocytopenia, which is much more in line with acceptable than what it was when it was just a flat starting dose for everyone at 300, which for the vast majority of patients was too high, and that rate was closer to 30%. So now we're sitting about 13%. Neutropenia, again, for olaparib and rucaparib, grade 3 or higher, or like febrile neutropenia is almost not seen. 5-ish% for grade 3 or higher, but febrile neutropenia you really don't see. And really for, again, with individualized starting dose with niraparib, it's a little bit higher, maybe in the 10% range, but we don't see a lot of complicated neutropenia with PARP inhibitors. So with any of them. So the real difference really comes down to that kind of doubling of the severe thrombocytopenia risk from 6-ish to 13-ish% between olaparib, rucaparib, and then up to niraparib.
Okay, so it sounds like we've done well with coming out of the blocks, like at the first dose, with doing individualized dosing for niraparib to combat some of the hematologic side effects. And for the others, we start and then kind of monitor how the patient's ongoing. And maybe for the listeners, maybe you could tell us, what's your strategy for monitoring, that first cycle across these patients with respect to their adverse events? Like, what kind of orders do you write for that first cycle across these 3 different, drugs that we commonly use?
What we do here is, which I think is recommended across the board for niraparib, when you initiate niraparib, it's weekly labs for the first month or 2. Really have to keep a close eye on the platelets. If even with the individualized starting dose, we can still see the platelets fall. And so we really pay close attention to those labs. I always when I speak about this, these aren't labs that you want coming in Friday after 5 and no one sees them till Monday. Like, these are labs you really need to see in real time, because if you see those platelets going down and it's high grade 1 or grade 2, you want to hold so they don't come in as a grade 4, 2 days later. So for niraparib, we are doing weekly until we're usually 2 cycles in and really solidly okay. And then we back off to once a month. Now, if you have to dose modify the niraparib for hematologic toxicity, say you go from 300 to 200, that weekly monitoring has to restart, until such point that you're stable for at least 1, full cycle, if not 2, and then you can back off, and just do monthly monitoring from there. And so that's what we do for niraparib. We also monitor blood pressure. We'll probably talk about that in a bit, but that's the other different aspect of the orders for niraparib that we put in place is self blood pressure monitoring, not crazy like we do on bevacizumab, but at least once a week, we want to know what the blood pressure is, just so we can monitor that over time and make sure that we are making necessary adjustments to keep our patients really healthy. For rucaparib and olaparib, honestly, you do not need to do weekly labs. So we really start with once a cycle labs, and we follow them from there. If you're going to see the grade 3 anemia with either of those drugs, we have actually nice time course data for olaparib that's been published. It happens like usually on the pre-cycle 3 labs. That's when you pick it up and you make the adjustments from there if necessary. So I'm not opposed to weekly monitoring for those 2, but really it's unnecessary. Even with the nuance of rucaparib is, of course, you see the transaminase elevations, a little bit of a sawtooth pattern with transaminases peaking like day 8 to day 15. But it's not associated with Hy's law. They resolve on their own. And honestly, I don't mean this to sound flippant, but I just don't want to know, because when they come in for the pre-cycle 2 or cycle 3, it's resolved, and there's no real liver toxicity. And if something is happening, I'll pick it up at that point. So I don't want to be responding to things that are not clinically relevant. So we just check it once a cycle.
Okay, so that makes sense. So in the first cycle with niraparib, we monitor the labs more closely because of the effects on hematologic toxicities, and with the others, doesn't seem to be so great during that first cycle. Obviously, we do see it with these other drugs, but we don't see it with such rapidity in that first cycle. I always like to relate that. I remember one of the very first patients I treated back several years ago with niraparib, on flat dosing. I asked how she was doing. I had her come back in a week to see how she was doing. And she said, I feel great, but I've got this weird rash. And so I looked at her, and she's petechiae eye up and down her chest and legs with a 4,000 platelet count. I was like, okay, let's take care of this, and we'll do some adjusting. And the good news is, though, at least with hematologic toxicity, we do have the flexibility of dose modifying. And obviously with niraparib, we learned that we could actually modify that dose pre-treatment or pre-initiation. And so that can help reduce those high-grade adverse events. So we talked a lot about hematologic toxicity. What about non-hematologic toxicity? You touched a little bit on the transaminitis, if you want to call it that, that we see with rucaparib. But we also see some other non-hematologic aberrations with PARP inhibitors as a class effect. And maybe I will drift a little bit into that potential creatinemia that we've seen with these drugs. What exactly is that, and why should we be concerned?
Well, I would never say we shouldn't be concerned, but we do see, just like the liver function tests, we do see this sort of not clinically relevant bump in creatinine. It's mainly been reported with rucaparib, where about 90% of patients will have some shift in their baseline creatinine. About 30% will bump into a different grade. And olaparib has the same thing. It's just not been classified as kind of precisely as rucaparib. It's about 20%. You don't see that with niraparib. And the reason you see it is that the drugs basically impact the OCT1 and MATE creatinine transporters. So it dislodges creatinine off of its transporter, so it becomes kind of free to measure in serum. It's not a reflection of worsening renal function. It's just you've sort of displaced it. So now you can measure more of it. And so, I think the key things with you, when you see a shift in the baseline creatinine, when you start someone on a PARP, is you do have to pay attention to it. You may look at it and go, okay, that's probably just the rucaparib. And then you check it again and it's the same, you've bumped up and then it plateaus and it just hangs out there. Okay, that's the rucaparib and you're really pretty much fine there. If you see it kind of going up and up and up, that's not the rucaparib or olaparib, like something is wrong. And she either has intrinsic renal dysfunction or needs a stent, or something else is going on, had a in from contrast load or something. So you have to work that up. So you do have to sort of pay attention to it and get a sense if it's just a shift in baseline for them. That's just kind of what you follow on PARP versus something that's increasing. And if you're really unsure, when just referencing your work, when you were still at MD Anderson, Rob, looked at measuring creatinine clearance. And so you can do a 24-hour kind of urine collection and look at renal function a little more precisely in that way and be reassured that you're not having a worsening renal function with that bump in creatinine, just to reassure oneself. But most of the time, I feel like it's pretty clear just based on the trend of the creatinine rise that it is or isn't related.
Great point. So we talked about some of the laboratory abnormalities. I think one of the ones that we mentioned early on that are actually probably even more problematic are things like asthenia and fatigue. And I know for those of our listeners here who probably, don't have a lot of experience with that, this could be pretty impactful. I remember, I had a patient on one of the trials who was responding dramatically, and it was just so exciting. And I was coming in there bouncing off the walls. This is fantastic. This is going away. Your tumor keeps shrinking. You've been on it for over 12 months. And she's like, listen, I can't take it anymore. I can't move. I can't get out of my chair. I appreciate that it's working, but on the other hand, I can't have a life. And so this is tough. And I think, maybe for those of our listeners who maybe haven't had as much experience, how do you address that adverse event?
I mean, you're absolutely right. Fatigue and asthenia can be very bothersome to patients who are ready to kind of, especially we're using PARP in the front line now. And so patients are done with chemo and they want to get back to their life, and we're giving them this 2 to 3 years of a PARP inhibitor, hopefully with some cure intent, but definitely trying to prolong their life. And so it's important medically, but they're ready to feel good again. And now we put them on something that, quite frankly, when I start PARP inhibitors in patients after any line of therapy, but now frontline, I'll just say the first 6 weeks of this drug are not going to be fun. You're like the fatigue onset is within a week. The nausea onset is within 3 days. And it peaks about, 3 weeks in, 4 weeks in, and then it starts to get better and you accommodate to this new normal that for the majority of women is acceptable. Patients will say they kind of just feel like a wet noodle or just like a wet sponge, just like they can do what they want to do, but just feels like squishier. They have to slog a little bit more, but they can still do what they want to do. But for some patients, it's more than that. And your patient is an example. And that's where I think it's important to remember a few things. One is you can dose interrupt before you dose modify. So in patients who are coming in going, look, I feel bad. I have an event coming. I want to go on a cruise. My daughter's having a baby. I want to help take care of the baby next week. You can hold drug for a few days and let them feel better, especially when you've been on for a few months already. Just take a few days and let them reground. Depending on how severe it was, grade 2, you can restart at the same dose. And a lot of times you can restart that and maintain dose. If it recurs again, then you can bring them down a dose. But dose interruptions kind of here and there throughout the years that we use PARP inhibitors are really helpful in helping patients just sometimes take a little breather from the background effect of these medicines. The other thing is that's important to remember, though, is that there's a lot of contributing things to fatigue. So not that the PARP is innocent, the PARP causes fatigue, but so do other things that compound it. So sleep hygiene, we are terrible, myself included. So I'm, the pot calling the kettle black. We are terrible at addressing sleep hygiene well. And a lot of these medicines impact and cause insomnia. And so if you're tired, your fatigue is worse. So is your pain and so is depression. We're not very good at addressing depression. Even low-grade depression in our patients compounds fatigue. Anemia compounds fatigue. And so the other thing that I do before I start a patient on a PARP, and actually I try to do it before I start chemo, but sometimes I forget, is I always send like the nutritional labs, iron and folate, because in my part of the world, we just have a lot of nutritional deficiencies that make it more likely for them to get severe anemia. And so if I replace those up front, I can kind of mitigate that ahead of time to try and keep them moving. So kind of thinking about those other reasons that are maybe making the fatigue worse than what the PARP is doing and addressing those can often make the fatigue grade 1 or 2 again, and a patient can accept that and feel like that's an acceptable way to live her life without modifying. So you really have to look at the whole picture, which honestly just takes time and some, sleuthing sometimes.
Yeah, that's some great sage advice. Yeah, dose interruption, dose modification are critical to maintain patients on treatment. And we've had our experience now with trying to combine PARP with other drugs. Chemotherapy has been too toxic, but obviously in the PALA-1 trial, we've combined it with bevacizumab, and fortunately, looking at that adverse event profile, it looks like we got basically each of them with their own individual toxicities, but we didn't see any additive or combinatorial effects. So that's really great. We just have a couple of minutes left, or just a minute left, actually. And I just wanted to maybe before we close out, talk a little bit about this really severe, kind of consideration of the second malignancy. So the MDS AML. Fortunately, this is not a common finding. It's obviously devastating when we do find it. But what is this relationship to the PARP inhibitors, and how do we kind of keep an eye out for it?
So we're talking about basically treatment-related myeloid neoplasms, of which AML and MDS are some, but there's many. There's just this spectrum of treatment-related myeloid neoplasms that we can see. And our patients are at risk for these really across the board because of some of the quote-unquote good things about ovarian cancer. There's nothing good about it, honestly, but on the positive side, we keep treating patients for years and years and years, and things repetitively work until they don't. And so these tumors and more importantly, the bone marrow of our patients are exposed to many, many, many lines of DNA damaging therapy over years. And so the biggest risk, honestly, of tumor-related myeloid neoplasms we're seeing now is like platinum, like the rise of platinum across all solid tumors. You see this bump in treatment-related myeloid neoplasms. So that's one. And then PARP inhibitors, of course, are DNA damaging agents. And so we've added those into the mix as well. And we're actually tracking this now. So it's not a new thing, but we are seeing more of it. And it is related not just to the PARP. PARP inhibitors don't cause this, but they contribute to it, along with repeated exposures to platinums and other, anthracyclines, all the things that we use. So we don't see a lot of it in the front line, even with now 7 years of follow-up in SOLO-1, which is a small study, but we're not seeing any signals that it's any different from 5 years of follow-up with Paula and Prima, for example. The rate's about 1.5 to 2%, which is probably our baseline rate. And there are patients who for some reason are at risk, and it's not CHIP mutations. We don't really know like what it is that tips somebody over early on, but there is that group. Where we see the bigger numbers coming in are in the recurrent setting in patients that have seen several lines of platinum-based therapy and then PARP inhibitors and have a BRCA mutation. So the largest risk was seen in the Ariel 4 study amongst the BRCA population, who are very heavily pretreated, all BRCA. So you already have a germline deficiency in how you repair DNA, and the rate there was about 13%, actually a little bit higher. But those are very late line, very heavily pretreated tumors and bone marrow. So we're learning this. We're trying to identify who's at risk. The move to PARP in the front line is appropriate because it works better there. And if we're going to cure anybody, we're going to do it in the front line until we can prevent this dread disease. And if you cure people or keep them from having to get more chemo quickly, you decrease the risk of just repeated exposure of bone marrow, and we're not going to see these high rates of treatment-related myeloid neoplasm. So I think that we've really addressed it by moving into the front line, but it doesn't mean any of us are satisfied with any of these sorts of development of any of these sorts of malignancies, because they are devastating. I will say, when I would see these early in my career, and I've been doing this now for quite a while, they were just universally lethal right away. Like, you diagnose them, and unfortunately our patients just died, and there was really no intervention at all. Now when we see them, I feel like our medical oncology colleagues who are leukemia experts and sometimes lymphoma experts do actually have effective therapies for some of our patients, especially those that are in remission or have excellent disease control. So you can buy some time, but it's still really limiting in terms of what else you can offer that patient for her ovarian cancer. So it's still really a terrible development, but I feel not as dismal as it was a decade ago because of the advances that our colleagues in HEMONC have made.
Yeah, that's for sure. They really have expanded that field quite a bit. Well, that's all the time we have today. Again, today we talked about toxicity of PARP inhibitors as they have migrated out of the recurrent setting to the frontline setting. Their anticipated hematologic and non-hematologic toxicities, their toxicity associated with single agents and combinations, and as you just heard, the late effects that we see with myeloid-related secondary malignancies. So great discussion. Thank you so much, Dr. Moore. And we look forward to PARP, the third podcast on PARP that we'll discuss a little bit about where this field is moving. And so excited. So please come back and join us for the third installment of this program. And with that, I'll be signing off. Dr. Rob Coleman at US Oncology here in Houston, Texas. And joining me was Dr. Katie Moore at the Stevenson Cancer Center in University of Oklahoma. Take care.
Remember to receive your credit and evaluate this program. Please visit morningcommutepodcast.com/ovarian cancer 2. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.